so going forward from a clinician treating perspective, are there things that you would recommend to other clinicians who see patients with LGS, or just a going forward, what can we kind of do to see some of those triggers early and act on some of those triggers? Just what's our forward-thinking thoughts, I guess, from this?
Yeah, absolutely. So I think there are two main take-home messages from our work on this study. So one, as I mentioned, are being on the lookout for any triggers. If a child with LGS presents to the emergency room, one of the most important things that we can do is review their history very carefully to see whether if there have been any new infective symptoms, but any changes in medications. Did we perhaps recently discontinue or gradually wean off the phenobarbital? Or did the family run out of medications and stop taking a medication, just did not get a chance to update the provider? The other another main take-home message from this study is one of our other findings, which was that when looking at the status epilepticus population in children with LGS, what we found was that there's a significant variability in duration of status. So some children can have status that lasts for several minutes to an hour or so, but there are others that can go on to have status for up to 8 days. What we found was that the median was around 4 hours, and the interquartile range, or the 50%, the mid 50% of these patients fall into that around 18 hours of status epilepticus. When we looked at this, we actually then also broke down the type of status that they were experiencing to see whether if we could find any patterns in the nature of the status epilepticus. Because bear in mind, children with LGS have frequent seizures on a daily basis. So how does a parent know that they're in status today versus, yesterday? So what we found was that 75% of our patients have intermittent status epilepticus, whereas 25% have continuous status epilepticus, or continuous seizure activity. So this plays a role in something to be mindful about for my colleagues out there. With this data in mind, knowing that over 75% of children are likely to have intermittent status in the LGS scenario, earlier identification of status can potentially help reduce the duration of status as well. And so I would say the main two key take-home messages here are, one, searching for a trigger for the status, and then identifying and resolving that trigger as much as possible. And secondly, being aware that status may manifest outside of what we know as the textbook version of status epilepticus, of continuous seizure activity. Rather, these children clearly our data shows, can have intermittent seizures, and that's what we need to be mindful about.